Welcome to Evidence-Based Cardiology Talks. This is the deep dive where we really unpack the latest, most relevant publications in contemporary cardiology for you.
Great to be here.
Today, we're tackling a fantastic state-of-the-art review from JACC Imaging all about myocardial strain imaging. We'll get into the theory, its current clinical uses, and maybe peek into the future a bit.
Sounds good. It's a topic that's, well, it's really central now, isn't it?
Absolutely. Consider this your fast track, all under the supervision of Dr. Caroli. You can find more at davefakercaroli.com.
Right. So strain imaging, whether we're talking echo or CMR, cardiac MR, it's fundamental for diagnosing a whole host of heart conditions. Essentially, it lets us measure exactly how the heart muscle fibers are shortening, thickening, and lengthening, in all four chambers as the heart beats.
Okay, let's just nail down the basics first. What exactly is strain in this context?
Well, the idea itself, strain, it actually comes from engineering, describing how materials deform.
Great, under stress.
Exactly. So for cardiac imaging, it's specifically about quantifying that shortening and thickening of the heart muscle, the actual mechanics of contraction.
Okay.
And for the left ventricle, the main pump, we're usually measuring longitudinal strain, that's the shortening along its length.
On the long axis.
Yep. Then circumferential shortening, sort of the squeezing motion.
Right in the middle?
Right. And radial thickening, how much the wall thickens up. All three contribute to, well, how well the LV pumps blood out.
The review mentioned other strains, too, less common ones.
Yeah, shear strains. We don't measure them as often routinely, but they give a fuller picture of the heart's complex 3D motion.
Like the twist?
Precisely. Circumferential longitudinal shear, that's what causes the LD twist.
Yeah.
Then there are others. Circumferential radial, radial longitudinal. They describe more subtle shifts between layers.
And how's it calculated? There was a mention of a Lagrangian description.
Yeah. Basically, it just means you're always comparing the muscle's current length back to a reference point. End diastole. The very end of the resting phase. It gives you a consistent baseline, L0, so to speak.
Got it. It's quite something how far this has come. The history section was interesting.
Oh, definitely. I mean, the initial ideas involved literally implanting tiny ultrasound crystals.
Wow, invasive.
Very. We're tracking little radiopaque markers with X-rays. But clinical strain imaging, the stuff we use, really took off with CMR cardiac memoir.
When was this?
Late 80s. They introduced tissue tagging. Think of it like drawing temporary lines or a grid on the heart muscle using radiofrequency pulses.
Okay.
And then you track how those lines deform as the heart beats. Early CMR tagging was massive for understanding segmental strain, in healthy hearts versus diseased ones.
Like in heart attacks or hypertrophy.
Exactly. That was the initial focus. And actually, CMR tagging is still seen as the clinical gold standard.
For validating newer methods.
Yeah, exactly. Like echo-based strain, which came later. There were other CMR methods, too, like tissue phase velocity mapping, measuring the speed of the muscle.
But they had limitations.
Lower temporal resolution, longer scan times. Practical issues.
Which brings us to echo. Ultrasound.
Right. Echo strain started with 1D tissue Doppler imaging.
Yeah.
But the real game changer for everyday clinical use was 2D speckle tracking echo, STE.
Speckle tracking.
Yeah. It lets us measure strain just by tracking these natural patterns, these speckles, within the standard ultrasound images. It's become the most common method by far now.
Okay, let's dig into those CMR tagging techniques a bit more. Spatial modulation.
Right, that's the most common one. It's a two-step thing. Create the tags, then acquire the images tracking them. Spatial modulation uses specific RF pulses to make that grid pattern.
And DEN-SE, that sounds intense.
Yeah. Displacement encoding with stimulated echoes. It's more complex, uses a different pulse sequence, but gets you really high spatial resolution, pixel-level displacement.
So super detailed movement tracking.
Very. Then there's strain-encoded imaging, similar tagging, but designed to capture strain through the image plane. It uses extra gradients to speed things up and generates a strain map directly.
And tissue phase mapping.
That one uses velocity encoding gradients to measure tissue speed, then you drive displacement and strain. But again, the longer imaging times can be an issue, potential for motion artifacts.
Okay. Now, CMR feature tracking, FT. That sounds different. No tags.
Correct. FT is post-processing. You take the standard sign images, the moving pictures of the heart we get routinely.
But the ones we always look at.
Exactly. And the software tracks small, naturally occurring features in the image, like the edge of the endocardium frame by frame.
So it follows bits of the image itself.
Yep. And from how those features move, it calculates deformation. If you know the frame rate, you get velocity and strain rate too. The key is you need really good quality sign images for it to work well.
Makes sense. Okay, shifting back to echo. Tissue Doppler versus speckle tracking. Why has STE taken over?
Well, echo is really the workhorse for clinical strain, no doubt. Tissue Doppler can measure strain, but STE, speckle tracking, is just much more widely adopted.
How does it work again? The speckles.
They're basically interference patterns from the ultrasound hitting the tissue. They move with the muscle. So the software tracks those speckles in your standard echo loops during post-processing to figure out the strain.
Ah, okay.
One key difference compared to, say, CMR-FT is that STE tracks these speckles within the muscle wall, while CMR-FT mostly tracks the contour, the edge.
So that could lead to slightly different numbers.
It can, yeah. Something to keep in mind when comparing studies or modalities.
What are the practical tips for using STE? What do we need to watch out for?
Good question. First, you need a well-defined region of interest, the ROI. Usually you want the full wall thickness.
Just the inner edge.
Right. And you need enough trackable speckles, basically. Decent image quality in that region. Different software might track slightly differently, too.
Okay.
Also, the direction of the ultrasound beam matters. Tracking is generally better along the scan lines. So apical views are great for longitudinal function.
But maybe not so good for radial.
Potentially less reliable,
Yeah.
manually, yeah. And image quality drops off deeper in the chest, naturally.
What about timing? Temporal resolution.
STE is generally fine for systolic motion, the main squeeze, but maybe not quite fast enough for really rapid events, like during the isovolumic phases, just before ejection or just after.
And a 3D STE?
Theoretically, great C-strain in all directions at once, but practically, the spatial and temporal resolution are lower than 2D STE right now, so it hasn't quite caught on for widespread use. You want a frame rate of at least, say, 40-50 frames per second for good 2D STE.
The review also mentions strain rate. Is this something we should focus on more? The speed of deformation?
It's an interesting idea. Peak systolic strain rate, how fast the muscle shortens during contraction, might actually be a better indicator of pure contractility.
Why is that?
It seems less affected by loading conditions, preload and afterload, and maybe chamber size compared to peak strain itself. But the catch is, current STE frame rates might not capture the absolute fastest strain rates, which happen really quickly during those isovolumic bits.
So we might be missing the peak.
Potentially. Tissue Doppler actually has better temporal resolution for that, and maybe these new high frame rate echo techniques will help STE catch up. It's an area to watch.
Let's talk about the different strain components, longitudinal, radial, circumferential, and that twist motion.
Okay, so a full 3D picture involves all three main strains plus those shear strains. But clinically, day-to-day, we really lean heavily on longitudinal strain.
Right.
It's just proven to be very sensitive. It picks up problems early. Radial and circumferential, usually measured from short axis views, tend to have a bit more measurement variability.
And the twist, or torsion.
Right, LV torsion. That's a rotational deformation from that circumferential longitudinal shear. We measure it clinically as the difference in rotation between the apex, the tip, and the base.
So the top versus the bottom twists differently.
Exactly. You get apical rotation during systole, and then this rapid back rotation untwisting in early diastole, which helps suck blood in for the next beat.
What causes that twist structurally?
It's the amazing spiral architecture of the heart muscle fibers. The inner layer, subendocardium, spirals one-way right-handed helix. The outer layer, subecardium, spirals the other way left-handed.
Opposite directions.
Yep. And because the outer subecardial fibers have a longer lever arm, they dominate, causing that counterclockwise twist of the apex during systole.
Fascinating. Can we measure this easily?
Both CMR and STE can measure rotation and twist. Key thing in imaging is making sure you include the very distal apex. A limitation of 2D echo is handling any out-of-plane motion of the LV base.
What about differences across the wall thickness? Transmural gradients?
Yeah, there are definitely gradients. The inner layers, for instance, tend to thicken more higher radial strain than the outer layers.
Can we measure strain layer by layer clinically?
People have tried looking at layer-specific longitudinal strain, but it's not really recommended for routine use right now.
Why?
Well, the layers are mechanically tied together, tethered. What one does affects the others. Plus, standard echo resolution side to side, the lateral resolution, isn't quite good enough to reliably separate these thin layers.
Yeah.
And studies haven't consistently shown clear differences between normal and sick segments across layers with different machines.
So stick to global or full-thickness segmental for now?
Pretty much. Similar issues apply to trying layer-specific stuff with CMR feature tracking too.
What else influences the strain values we get?
Oh, several things. Loading conditions are big preload. how full the heart is, and afterload, the resistance it pumps against.
Blood pressure, essentially.
Yeah, heart
Yeah.
rate matters too, and just the overall size and shape of the heart.
So context is important.
Very. The review showed a study where even mild mental stress raising blood pressure a bit reduced GLS. It really highlights why you should record BP during the scan and maybe avoid stressing the patient out. Prevent that white coat effect on strain.
Good practical point. How does strain compare to older things like MPSC and TAPC?
MAPSE and TAPC mitral and tricuspid annular plane systolic excursion, there are simple M-mode measures of longitudinal function.
Easier to get sometimes.
Often easier, maybe less dependent on perfect image quality than GLS. But the correlation between GLS and MPSE is only moderate, and there's just less clinical outcome data supporting MPSE as a direct replacement.
So not quite interchangeable.
Not really, but maybe in a pinch, like a bedside echo in the ICU where image quality is tough, MAPSE, perhaps normalized LV size, could give you a quick idea if there's major LV systolic dysfunction.
Okay. Let's switch gears to myocardial work. That sounds like a step beyond just deformation.
It is. Myocardial work tries to integrate both the force the muscle generates and how much it deforms. It gets closer to the actual energy expenditure, the oxygen consumption of the heart.
How do we measure that non-invasively?
Well, traditionally we use pressure volume loops, but those are invasive. Now we can estimate LV pressure non-invasively using echo and cuff pressure and combine that with STE strain data to create pressure strain loops.
Like a virtual pressure loop.
Kind of, yeah. There's also a more clinically used method that incorporates aortic diastolic pressure to calculate various myocardial work indices. Need to be careful in conditions like aortic stenosis or HOCM, where cuff pressure doesn't equal peak LV pressure. You need to adjust for the gradient.
Is this ready for prime time?
The initial data looks promising in various conditions, but we still need more studies linking these work indices directly to long-term patient outcomes. It's definitely an area of active research.
And mechanical dispersion, what's that telling us?
Mechanical dispersion is about how uniform the timing of contraction is across the different LV segments. High variability, large dispersion means some segments are peaking much later than others.
And that's bad.
It's been linked to increased risk of arrhythmias, like dangerous ventricular tachycardias, first noticed in long QT syndrome, but also seen post-MI and in non-ischemic cardiomyopathy.
How's it calculated?
You look at the standard deviation of the time from the ECG Q wave or R wave to the peak shortening in each segment.
Seems like a useful risk marker then.
Potentially, yes. It's promising, but like myocardial work, it needs more validation in big prospective outcome trials before it becomes routine.
Okay, let's zone in on the specific chambers. For the LV, what are the key clinical messages about strain?
For the LV, global longitudinal strain, GLS, is the star. It's just super sensitive for picking up even mild systolic dysfunction, often before the ejection fraction drops.
Across many diseases.
Yeah, heart failure, CAD, diabetes, hypertension, cardiomyopathies. It's broadly applicable. Circumferential and radial aren't used as much clinically, partly due to variability issues we mentioned.
Any pitfalls when measuring LV strain?
Definitely. Getting good non-foreshortened views is critical. Foreshortening makes the ventricle look shorter, which artificially increases the GLS value, makes it look better than it is.
So technique matters.
Hugely. Also, ROI placement, make sure you get the full wall, not just the endocardium, especially if the wall is thick. Local bumps or bulges can throw off tracking too.
And timing.
Crucial. Accurately defining end diastole and end systole, usually based on Valplix or Doppler, is vital. ECG triggers can be off, especially with wide QRS complexes. Manual adjustment is often needed.
What about segmental strain?
GLS is reproducible because it averages many segments. Individual segmental strain is much more variable, prone to noise. So don't overinterpret a single weird segment. Look at the overall pattern, the bullseye plot, qualitative assessment, post-systolic shortening, dyssynchrony patterns. Those are diagnostically important.
Moving to the left atrium, how's strain used there?
LA strain is usually measured from a good apical four-chamber view tracing the LA border. Global longitudinal strain is the common measure.
What does it tell us?
We talk about different phases. Reservoir strain reflects LA filling during ventricular systole. Pump strain reflects the act of LA kick before ventricular diastole. And recoil strain is passive emptying.
Which one is most useful?
Reservoir strain probably has the most data behind it, especially relating to LV filling pressures. Pump strain gives info on LA contractility, but can be tricky to measure, especially with fast heart rates, and it's obviously absent in atrial fibrillation.
Are the normal values well defined?
The ranges are quite wide, honestly. Biological variability, using non-dedicated views, sometimes manual tracing, adds noise. Dedicated LA software helps reproducibility.
And the right ventricle and right atrium.
RV strain is gaining traction. RV free wall longitudinal strain, measured from an RV-focused apical view, seems valuable for assessing RV function in cardiomyopathies and adds prognostic info. Again, need careful ROI on that thin wall. Layer analysis isn't feasible.
And the RA.
Right atrium, much less data. Normal ranges seem extremely wide in meta-analyses, which might limit its clinical utility for now.
Okay, a really key point. Why is strain better, or at least more sensitive, than ejection fraction sometimes?
Great question. GLS often picks up problems earlier than LVEF. Why? Well, the longitudinal fibers, mainly in the subendocardium, are often hit first by disease processes.
So GLS drops before EF.
Often, yes. EF is more influenced by the mid-wall circumferential fibers, plus the heart can compensate. You might get reduced longitudinal shortening, but maybe increased radial thickening, or the LV might remodel, change shape, which can preserve the overall EF for a while, even when the underlying muscle function reflected by GLS is declining.
So GLS unmasks problems EF might hide initially.
Exactly, especially in things like HSPEF, hypertensive heart disease, early cardiotoxicity, infiltrative diseases.
And thinking prognostically, how do GLS and mechanical dispersion perform?
Both are strong prognostic markers. GLS predicts outcomes robustly in many conditions, sometimes better than LVEF, like in acute heart failure.
And dispersion.
Mechanical dispersion independently predicts arrhythmic events, particularly post-MI, even when EF is preserved over 35%. Combining GLS and dispersion seems even more powerful for predicting risk. How we use that to guide therapy, though, is still being worked out.
Let's run through some specific diseases where strain really shines. Ischemia.
In ischemia, you can see reduced shortening, maybe paradoxical lengthening, or that post-systolic shortening we talked about, contracting after the aortic valve closes. Useful signs, though not 100% specific.
Is it used routinely for diagnosing CAD?
Not widely for routine diagnosis yet.
Yeah.
Stress echo with strain is debated challenges with high heart rates, motion, lack of clear cutoffs for specific coronary territories. But ESC guidelines suggest a role if EF is normal, but you see regional dysfunction, and recommend GLS for risk assessment if EF is over 35%.
What about dyssynchrony and CRT?
Strain is very helpful here. It can help distinguish electrical dyssynchrony, like LBBB, which benefits from CRT, from contractile issues due to scar.
How?
In LBBB, you see characteristic patterns,
Mm-hmm.
early septal activation, sometimes a septal flash, delayed lateral wall contraction, maybe systolic stretch. Strain can quantify this. Patterns like the systolic stretch index or measures of myocardial work asymmetry can help predict CRT response better than older methods.
Hypertrophic cardiomyopathy, HCM.
Strain patterns are often very patchy, heterogeneous. You frequently see reduced longitudinal strain, especially in the thickest segments. Sometimes that apical sparing pattern. GLS is often reduced overall, correlates with fibrosis on CMR, and has prognostic value.
Cardiac amyloidosis. This seems like a classic use case.
Absolutely. You often see impaired basal strain early on, even before HF symptoms. This creates that classic base to apex gradient, the apical sparing pattern on the bullseye plot. It's a key diagnostic clue.
Does the pattern differ between amyloid types?
Not clearly, no. But the apical sparing, maybe combined with the EF-GLS ratio, is a big red flag suggesting amyloid. Strain parameters also predict outcomes and might help monitor treatment response in both TTR and AL amyloidosis.
What about arrhythmogenic RV cardiomyopathy, ARVC?
CMR is still key for diagnosis, looking at RV size and function, but RV strain on echo is emerging as a really promising early marker. You can see abnormal RV free wall strain even in asymptomatic family members with the gene mutation when other echo measures are normal. It might help track progression and predict arrhythmias.
Dilated cardiomyopathy, DCM.
Less role in diagnosing obvious DCM with low EF, but maybe for screening relatives. In patients with conduction delays needing CRT, segmental strain and work analysis can help predict response, similar to LBBB.
Other conditions, cardio-oncology, valves, HFpEF.
Yes, yes, and yes. Cardio-oncology guidelines recommend monitoring with EF and GLS if available, as GLS can detect toxicity early. In valvular disease like severe AR or MR, GLS can show subclinical LV dysfunction despite preserved EF and predicts post-op outcomes. Same in aortic stenosis. And in HFpEF, patients often have abnormal LV and LA strain despite normal EF, helping differentiate it, and LA strain correlates with filling pressures.
That brings us back nicely to LA strain and LV filling pressure. How strong is that link?
It's quite strong, especially for LA reservoir strain. It's a good, non-invasive marker of elevated LV filling pressure. essentially LV preload.
Better than other LA strain measures.
Reservoir strain has the most evidence. LA pump strain also correlates, but is affected by more factors like LA contractility itself. Reservoir strain seems more robust.
Can we use it standalone to determine filling pressure?
Probably not quite yet for major clinical decisions. The association is strong, especially with reduced LVEF, but maybe not tight enough to replace invasive measures or a full diastolic assessment. But it's a very valuable piece of the puzzle. Combining it with other parameters like mitral inflow patterns might be the way forward.
Okay, wrapping up the comparison, echo versus CMR for strain. Quick pros and cons.
Sure. Echo, STE, is available cheaper, real-time, angle-independent. Cons: window-dependent, lower resolution sometimes. CMR, tagging, or FT, has great image quality, not window-dependent, better for scar fibrosis with gadolinium. Cons: longer scans, less available, more expensive, lower temporal spatial resolution than echo, patient limitations.
Do they give the same numbers?
Generally good agreement for global strains like GLS between STE and CMR tagging. CMR FT values tend to be a bit lower than STE. Remember, they track slightly different things, speckles within the wall versus contours. Segmental strain is more variable with CMR FT, not really for clinical use yet.
What about vendor differences? AI, the future.
Inter-vendor differences exist for both STE and CMR FT, though maybe not the dominant source of variability overall. Standardization efforts are ongoing. 3D techniques hold promise. And AI is huge. Automated segmentation and analysis are making measurements faster, more reproducible. This will likely boost clinical adoption. The future is probably combining strain with other imaging data structure, perfusion, maybe metabolism using AI for integrated diagnosis and prognosis. Point-of-care strain with AI guidance is also emerging.
So the key takeaways from this deep dive.
I'd say LVGLS is your sensitive marker for subtle systolic dysfunction. Segmental strain patterns are crucial in cardiomyopathies. LA strain gives strong clues about LV filling pressure. And both STE and CMR strain are definitely ready and valuable tools in our clinical toolbox now.
Excellent summary. It really sets the stage for the future.
Indeed. And the big question remains, how will AI and combining these imaging modalities really push strain imaging forward to significantly improve patient care and outcomes? That's the exciting part to watch.
Absolutely. A huge thank you for that insightful discussion. And thank you for getting us on evidence-based cardiology talks. Don't forget to subscribe on Spotify and YouTube for more deep dives into contemporary cardiology research.
Always a pleasure.
This discussion, as always, was under the expert supervision of Dr. Caroli. You can find more resources at drcaroli.com. We'll see you next time.